Welcome everyone to today's webinar, An Introduction to SAMHSA's new guide, Best Practices for Successful Reentry from Criminal Justice Settings for People Living with Mental Health Conditions and/or Substance Use Disorders. While we allow time for attendees to filter into the room, I welcome you to let us know where you're joining from today. Go ahead and familiarize yourself with the chat box and let us know your location. I'm joining today from sunny Phoenix, Arizona, where I think we're on day 1000 over 100 degrees. So that's where I'm joining from today. It's great to see you all in the chat box where you're joining from, so many different places, and we thank you all for being here today with us and sharing this hour together. For your situational awareness, all attendees have been muted and are unable to share video or sound. Thank you again for joining us. Let's go ahead and get started. So once again, welcome everyone to this SAMHSA, Abt Associates, and MHTTC hosted webinar on successful reentry from criminal justice settings for people living with mental health conditions and/or substance use disorders. My name is Felicia Benson, and I'm the project coordinator for the Mental Health Technology Transfer Center Network Coordinating Office. And I'm going to go ahead and run us through a few housekeeping items. We've made every attempt to make today's presentation secure. If for some reason the presentation ends unexpectedly, we'll follow up immediately with your email. All participants have been muted, so while you listen to today's presentation, if you have a question for the presenters, please enter it into the Q&A box that you'll see down at the bottom, and we'll do our best to answer as many questions as possible. If for any reason you need tech help or for any logistics questions, please enter them into the chat box and I will respond to you. At the end of today's webinar, you're going to be asked to complete a brief survey. We hope to get feedback on how to best provide opportunities such as these in the future. So we really would appreciate your honest opinions. This event is closed caption, so please be sure you click on that closed caption icon so that you can view those captions. This session is being recorded and it will be made available on our website. You'll also receive a follow-up email with the link to the video recording, the slides, and information on how to access the certificate of completion. If you want to follow along with the slides today, I will drop the link in the chat momentarily so that you can download them and follow along. Otherwise, we are on social media, so please follow our network on Facebook and Twitter. A quick disclaimer that we're providing this webinar through funding from SAMHSA, and the opinions expressed here are the views of the individual speakers. We want to recognize that our network and speakers strive to use affirming, respectful, and recovery-oriented language in all of our activities. These are our values and they are essential to our mission. Before we get into the main topic for today's presentation, I just want to take a moment to share a little bit about the MHTTC Network. We are a network of 13 centers that provide free resources, training, and technical assistance on mental health promotion, treatment, and recovery. Our main goal is to accelerate the adoption and implementation of mental health-related, evidence-based, and promising practices across the nation. I invite you to take a look at our website, mhttcnetwork.org, and get connected to our centers, in addition to accessing all of our free, readily available products and resources. I will now hand it over to Joseph Bullock from SAMHSA to start us off. Dr. Bullock received his doctorate from Virginia Polytechnic Institute and State University. He is the former director for SAMHSA's Center for Substance Abuse Treatment and is currently a senior public health advisor with SAMHSA's Policy Laboratory. For this guide, Dr. Bullock served as a key liaison between the Policy Lab and the guide planning team, and has also been involved with many of the other EBRC products. Dr. Bullock, welcome.
Welcome. And first of all, I'd like to thank everyone who joined us for this webinar today, especially those who are, whether you're working boots on the ground, working in administration, management, whichever part of corrections. Thank you so much for joining us on this webinar today. And we certainly hope that you find the guide that we're going to share with you today to be very helpful. Again, my name is Dr. Joseph Bullock. I am a senior public health advisor with the Substance Abuse and Mental Health Services Administration. I am so pleased to kick off this webinar about an important new guide from our Evidence-Based Resource Center. Best practices for successful reentry from criminal justice settings for people living with mental health conditions and/or substance use disorders. So during the next hour, we'll learn about the process to develop the guide and the research that's included. We'll also hear from a member of our technical expert panel who provided guidance throughout the guide's development process, and from 4 organizations featured as case studies who will discuss how they implemented the evidence-based practices for the specific populations that they serve. So a little bit about this guide. This guide was developed under the leadership of SAMHSA's National Mental Health and Substance Use Policy Laboratory in collaboration with the Centers for Mental Health Services and Substance Abuse Treatment. This guide is one in a series of products that cover diverse topics. Over the past 3 years alone, SAMHSA has released nearly 36 evidence-based practice guides, practical guides, and advisories on a wide range of topics related to substance use and mental health. 3 of the recently published guides focus on community engagement, community-level policies to prevent alcohol misuse, and adapting evidence-based practices for under-resourced populations. This year, we are working on 6 additional products. SAMHSA's vision and the underlying foundation for the guide is to reflect scientific rigor and make recommendations from the evidence base, provide expert consensus, be comprehensive and modular. Practitioners, administrators, and other stakeholders will be able to use this guide in its entirety, or simply just take sections that are relevant to your needs. Each chapter will stand on its own. It also is designed to be accessible to the field. So with that, we are pleased to announce that this guide, Best Practices for Successful Reentry from Criminal Justice Settings for People Living with Mental Health Conditions and/or Substance Use Disorders, was posted to the SAMHSA store on August the 31st, 2023. To speak more about the guide, I'd like to introduce Dr. Stephanie Fahy, Senior Associate at Abt Associates, and the lead for this guide. Stephanie?
Thank you so much, Joe, and welcome to everyone. It's so exciting to see we have 2,000 people on this webinar from all over the country. So I'm just really happy to be here today and talk about this guide. Before I start, I wanted to provide just a brief overview of the issue. First, and many people may know this, looking at the research, we see that individuals living with mental health conditions are traditionally and actually, can we forward the slide? Sorry. Thank you. The research tells us that individuals living with mental health conditions are traditionally overrepresented in criminal justice settings in the United States, including in jails and prisons and on probation and parole. Nearly half of all individuals incarcerated in state prisons have a history of a mental health disorder. Past available estimates suggest that approximately 16% of inmates in state prisons and 17% of individuals in jails are living with a serious mental illness, compared to the current estimate of 5.5% of all adults age 18 or older within the general population. Additionally, compared to people living without a mental health condition, those with serious mental illness are likely to spend more time in jail before adjudication, serve longer sentences, be rearrested for the same crime, and have higher recidivism rates. We also see that past estimates of substance use disorders among incarcerated populations are 53% in state prisons and 68% in jails. This is in stark contrast to the past year prevalence of 16.5% among people aged 12 and older in the general population. In addition, as you can see from the graphic on this slide, the presence of mental health conditions and substance use disorders over the course of one's lifetime is associated with higher odds of lifetime incarceration. For example, the odds of someone with comorbid substance use disorder and mental health facing lifetime incarceration are 6.7 times the odds of someone without comorbid substance use disorder and mental health. This tells us that those reentering the community need comprehensive integrated services to address mental health, substance use, and trauma. Next slide, please. Unfortunately, we also know that individuals living with mental health conditions and/or substance use disorders who reenter the community from jail and prison often encounter significant barriers to behavioral health treatment, stable and safe housing, meaningful employment, and other recovery support services. Planning and support should begin during a term of incarceration and continue post-release to address the needs of each individual and promote continuity and strong linkages to care. Additionally, appropriate support during reentry into the community can reduce the risk of recurrence of symptoms, as well as risk of overdose, death by suicide, or risk for reincarceration. Next slide, please. So I wanted to talk a little bit about the focus for this guide. So the focus is on evidence-based interventions and practices that may be useful during the reentry period for individuals living with mental health conditions and or substance use disorders. This guide includes both the evidence supporting these interventions and specific strategies for providers, staff, and organizations to consider when implementing them. Specifically, this guide provides information and implementation guidance on 3 interventions. It also provides resources related to evaluation. There are 5 chapters in this guide. Chapter 1 provides an overview of the prevalence of mental health conditions, substance use, and co-occurring disorders among individuals who are incarcerated. It also includes outcomes used to measure successful reentry, challenges associated with reentry, and implications of incarceration for individuals living with mental health conditions and or substance use disorders. Chapter 2 describes the current evidence on 3 interventions to improve reentry outcomes for these individuals. Chapter 3 provides strategies for implementing these interventions. In Chapter 4, we present 4 case examples of organizations that are implementing the interventions discussed in Chapter 2. And finally, Chapter 5 provides guidance and resources for evaluating behavioral health interventions in the context of reentry from criminal justice settings. In developing this guide, we started by working with our colleagues at SAMHSA and our subject matter expert, Barry Zach, to identify the goals, audience, and intended population of the guide. We also created a technical expert panel made up of identified scholars and practitioners who had broad expertise. The panel included community providers, academics, federal agency representatives, and administrators with clinical, personal, and applied experience. Next, we conducted a systematic literature review of evidence-based interventions designed to improve behavioral health and related outcomes for individuals leaving jail and prison. We also identified 4 case examples from different communities that have implemented these interventions. Finally, we collated guidance, tools, and resources to support implementation and evaluation. Next slide, please. So I'm very pleased to introduce Angel Sanchez, a technical expert panel member and U.S. Department of Justice Bureau of Justice Assistance Second Chance Fellow. He will discuss the role of the technical expert panel in the development of this guide. In addition to being a visiting fellow, Mr. Sanchez is a formerly incarcerated leader and attorney. He earned his BA summa cum laude from the University of Central Florida's Burnett Honors College and his JD magna cum laude from the University of Miami School of Law, where he was a member of the University of Miami Law Review. Angel?
Thank you for that introduction, Stephanie, and welcome to everyone. As you heard, my name is Angel Sanchez, and I'm here to share with you the technical expert panel's role in the development of this guide, what we would call the TEP for short. And so one of the things that I want to lay out briefly is that I'm going to share with you the purpose of our technical expert panel, or TEP. I'm going to share with you the makeup of our team, and then finally how we engaged with Abt, the subject matter experts, and the guide. So to start, next slide, please. As you can see here, these are the members of the technical expert panel. And as you heard, many of us are practitioners, academics, government representatives, and even like myself, someone that's formerly incarcerated and system impacted. The purpose of the TP was to help the team identify research studies and data that was most relevant to the topic of the guide, to reach a consensus on the evidence-based practices that we would feature in the guide, identify the field's needs in order to implement and to implement the practices effectively, We also suggested tools and resources that will promote the evaluation and quality improvement process to monitor key outcomes. And what I would call somewhat most importantly, we reviewed the guide and provided critical feedback on all aspects of the guide's chapters and development, which you already heard about. So chapters 1 through 3 and then 4 and 5. Now I'll share a little bit about the process on how we engage. Initially in November of last year, so November 2022, we met for about 3 hours. And during that meeting, that's where we provided the feedback that would lay out the scope and it would frame the guide. And we planned the literature review throughout that meeting. After that, chapters 1 through 3 were drafted and we reviewed it, gave critical feedback, and then met again in January of 2023, this year. And during that meeting, we expounded on our feedback that we gave on those chapters, chapters 1, 2, and 3, the ones that you heard about. So the outline or the framing of the guide, the literature that was engaged, and the implementation guidance in chapter 3. So then at the end of that meeting, we also planned with Abt what would be the continuing literature review and the evidence-based programs that would be highlighted. And then finally, chapters 4 and 5 were drafted, and we again engaged with those drafts of chapter 4 and 5, gave feedback on it, and then had open office hours in which we could consult with Abt and provide our advice and feedback on it. I would say that some of the examples of suggestions that we provided was the importance of medications for opioid use disorders for people reentering the community and the positive impact that reentry supports can have on behavioral health. We also provided some critical suggestions on the literature review and the outcomes that focus emphasizing engagement in services, well-being, and other re-entry or recovery supports in addition to recidivism. And I want to share a little bit more on that. As you'll see in the introduction, recidivism has been the measure that has for a long period been used as a measure of success. But we highlighted how that is sometimes not a proper measure of success and how there are other better measures of success, such as well-being. And so you see that discussion happening immediately in the first chapter. That was in response to the TEP's feedback. So it was really an honor and a pleasure to participate on this very important work, to give voice and representation to people that were system impacted. To that end, I personally gave a lot of feedback in terms of how we framed the discussion and how we centered the humanity of the individuals being served. And you know, I could not have been more happier that, with our role in this guide. So at this point, I will conclude my part of this presentation and turn it back over to Stephanie.
Thank you so much, Angel, and it was a pleasure having you as part of the TAP, and really appreciate all of your thoughtful feedback and guidance. And I remember having the conversation about recidivism, and it's a very important conversation to have, and I'm glad that we were able to talk about that in the guide. So if we could please go to the next slide. I'd like to spend just a few minutes now talking through the process of identifying and reviewing research on the interventions that we included in this guide. First, we looked at systematic reviews to identify existing studies that focused on individuals living with mental health. And I just realized my video is not on. Sorry about that. So again, we looked at systematic reviews to identify studies that focused on individuals living with mental health conditions and or substance use disorders re-entering the community from jail or prison. We shared a long list of these potential interventions with SAMHSA and our experts, as Angel just mentioned, and they helped us narrow these down to 3 approaches, which we ultimately included. With these 3 approaches in mind, we screened 676 abstracts to identify articles that met our criteria. So some of the criteria included articles published since 2002 and written in English. But I think more importantly, a key to our approach was that The criteria included using people or including people re-entering the community from jail or prison with behavioral health conditions, since that's the focus of the guide. Lastly, we extracted information and synthesized the findings, and that's what appears in Chapter 2 of this guide. Next slide, please. So now I'll briefly cover the 3 interventions that we included in Chapter 2. The first intervention is medication for opioid use disorder or alcohol use disorder, commonly known as MOUD/MAUD. This is the use of a medication that targets the brain and is often used in combination with counseling and behavioral therapies to provide a whole person approach to the treatment of opioid and alcohol use disorders. This approach is designed to prevent overdose or reduces alcohol use and sustains recovery. The most common FDA-approved medications used to treat alcohol use disorders are acamprosate, disulfiram, and naltrexone. The FDA has approved 3 medications for opioid use disorders: buprenorphine, methadone, and naltrexone. The second intervention that we included is case management. It's a service modality in which providers broker services and support clients in identifying and accessing needed supports by making linkages and warm handoffs to mental health and substance use disorder treatment, housing, and social services. The third intervention that we included is peer and patient navigation. Peer services encompass a range of activities and interactions between people who share similar experiences of being diagnosed with mental health conditions, substance use disorders, or both, and who are re-entering the community. Peer navigators provide recovery-oriented treatment planning and non-clinical services, such as housing support, employment services, mentoring, and support groups. In the context of this guide, peers are individuals who have experience with mental health disorders and/or substance use disorders and/or have criminal justice experience. Patient navigation refers to the use of trained healthcare workers to reduce barriers to care for individuals returning from criminal justice settings. Patient navigators help individuals navigate complex healthcare and social service systems to improve access to care and treatment. Next slide, please. We're now going to hear from 4 organizations who are listed on this slide that have implemented one or more of these approaches and the lessons that they have learned through their experiences. These are also included in Chapter 4. Next slide, please. So our first example comes from Serving Children and Adults in Need, or SCAN, based in Webb County, Texas, and presented by Clarissa Cabello. Clarissa has worked at SCAN for a little over 9 years now and is currently overseeing SCAN's Border Reentry and Community Integration Program. She is a licensed master's social worker and licensed chemical dependency counselor. She has worked with survivors of sexual assault, individuals experiencing homelessness, and living with a mental illness and/or co-occurring disorder, as well as people re-entering the community after a period of incarceration who have co-occurring disorders. Clarissa?
Hi, Stephanie. Thank you so much. So a little overview of SCAN. It stands for Serving Children and Adults in Need. We're actually located in Laredo, Texas, which is South Texas, border with Mexico. We've been providing services for a little bit over 40 years now, and it's basically an agency that is made up of about 30 different programs, ranging from prevention, intervention, and treatment, both substance and mental health treatment. The way that this specific project has been able to best fit within our agency within the past 5 years is being able to have the therapist actually meet the individuals while they're still incarcerated. We've been able to establish that working relationship with local facilities here in Laredo. So they're able to meet the clients where they're at, provide a screening, assessment, better get to know each other, build that rapport, and start setting up a treatment plan prior to their release. Sometimes we go ahead and get the clients right after they're released, which works the same. It works well. We actually have an in-house medicated assisted treatment program, which provides the buprenorphine for opiate use disorders. So that has been really successful when an individual is seeking that treatment, because we try to avoid having any, lapses or space between their release and re-entering the community. The therapists were able to provide the case management as well as peer-to-peer services. We do group therapy. We have within SCAN a drop-in center, which is a 24/7 facility. So when the therapist may not be available between Monday through Friday, this facility is available for them 24 hours, right? That's a little overview of our program within SCAN and how this program has best fit within. Any challenges that we faced during these past 5 years, mainly maybe in the beginning, was filling up staff positions and lack of resources. The way these things were addressed was we were able to, throughout time, hire increased salaries for staff, provide clinical support that has been ongoing. We meet with therapists on a weekly basis. We have open door policies with all supervisors. Right now, I'm overseeing this specific program. However, any other program directors that are available are open to help anyone. We've also met with we have a local university here. We met with graduating classes to explain the services that we provide, to explain this program, and be able to guide them through the SCAN job application process to have that a little bit more clear to them. Another thing was being able to focus on secondary traumatic stress within our staff. So we are able to approach things in a trauma-informed way for both the clients as well as the staff members. So we've been able to retain staff and be able to provide support on different cases, especially because of the history that might come about during the clinical setting. Right. When it comes to lack of resources, Laredo is pretty small, but there is different agencies. So the way we've been able to overcome that is since we've been around for so many years, we've been able to establish working relationships with different agencies such as the local soup kitchen, the homeless shelter, local housing authorities, mental health authorities, just to name a few. So we are a part of their stakeholder meetings, as well as we have quarterly stakeholder meetings, which has been able to allow us to learn about different funding opportunities that people may have, as well as maybe staff cases, of course, upon consent of the client. And that's how we've been able to try to, take care of those challenges that might come up, especially with housing. After being incarcerated a period of time, sometimes they lose the housing that they had prior to being incarcerated, or even when it comes to their primary documents, such as a birth certificate, social security, and ID card. So that's part of the case management approach, to try to also engage them in the workforce, right? So I guess the biggest takeaway that we've gotten in these past 5 years with having this program has been, to have these working relationships established from the beginning, or develop them. They have been one of the biggest components, being able to link individuals to different things, whether it be housing, MAT services for opiate use disorder, alcohol use disorders, residential detox, and being able to provide that support as well for the staff, right? To be able to retain staff. And we've had an amazing team on board. So yeah, we look forward to continuing to provide services for individuals within our outpatient substance use treatments, as well as our residential facilities. But thank you for the opportunity for us to share a little bit of the work that we've been doing with SCAN.
Thank you. Thank you, Clarissa, for sharing that. You're doing amazing work, and it was a pleasure being able to speak with you and include that in our guide. So hopefully people will be able to read through that case example. Next, we're going to hear from Curtis Penn, and could we please just advance the slide? Thank you. He's the Division Director for Justice Services at the Felton Institute in Alameda County, California. Mr. Penn directs programs that provide services via case managers and clinicians for people who have been impacted by unaffordable housing and decreased mental health services, to name a few. Before joining the Felton Institute, he worked as the director of Project Rebound at San Francisco State University, He has a master's in public health administration with an emphasis on criminal justice and public policy. Curtis?
Yes, thank you so much for that introduction, Stephanie. Hello, everyone. My name is Curtis Penn, Division Director of Justice Services with Felton Institute. I will speak briefly about our agency, Felton Institute. We've been around since 1889. We serve clients from birth to end of life. We have a number of programs. We have an early childhood program, senior division program, as well as a adult division program. The Justice Service Division is relatively new in comparison to our other divisions within Felton Institute. I will also cover the genesis of our SMI program, which we call Success Moving from Incarceration. I will go into the services that we provide, the program goals and objectives, program design, and in with the multidisciplinary team approach that we use and the challenges that we had faced, particularly during the height of the COVID pandemic. So as Stephanie had stated, San Francisco Felton Institute provide services in Alameda County and San Francisco. SMI program Success Moving from Incarceration, the genesis was based on Prison Realignment Act, AB 109, which was a public safety legislation that was passed in 2011. Based on this legislation, it changed the supervision from state to county jurisdiction, where these individuals were now getting out of state facilities, state correctional facilities, and now being supervised in the county supervision through Alameda County Department of Probation. The services that we provide in our SMI program consist of mental health services, which involves a preliminary assessment, a secondary assessment. We also provide individual and group therapy. We provide case management and brokerage, crisis intervention, and medication support. Our program goals and objectives include providing clients with psychiatric and behavioral health treatment in order to improve client wellness and community functioning. We connect clients immediately to resources to meet urgent and essential needs. We promote fiscal and benefit stability among our clients. We link participants to primary care services, substance abuse treatment, and other health care related services. We connect participants with short-term and long-term support services such as housing assistance, public transportation vouchers, emergency food, gift cards, and personal grooming. We assist clients in applying for public health benefits, connecting disabled clients without Social Security insurance to SSI, advocating for SSI services. The goal, obviously, to reduce recidivism and promote self-efficacy, assist clients to integrate back into the community successfully, and reduce hospitalization, incarceration, and other emergency services. Our program design, we work closely with Alameda County Probation and Alameda County Behavioral Health. We have a 3-phase model that consists of a stabilization phase, which averages 30 to 60 days from the time that they are released. Again, working with clients to meet their immediate needs and initiate connections and linkages to mental health, medical, and substance use disorder, and also assist clients with medical enrollment and finding a medical home. We also have the transitional phase, which averages 4 to 6 months. And in this phase, we prioritize helping clients to obtain linkages to at least 3 presenting aids, successful transition into the community. We look to help clients treatment plan, continue to provide mental health treatment, and start transition with clinical support. The third phase, sustainability phase, is the last, and it averages 4 to 6 months. In this phase, we help clients to sustain positive linkages that address at least 3 presenting needs and obtain linkages to at least 1 additional presenting need, supporting clients in maintaining self-efficacy, as well as family reunification. Our approach is a multidisciplinary team approach that consists of peer support specialists with lived experience, case managers, clinical case managers, psychiatric nurse practitioner. The clients are referred to us through Alameda County Probation. Upon that referral from the county jail, we make sure that clients meet the eligibility AB 109 criteria. Once the program accepts the individual, it sends a confirmation to the referral source. A case manager reaches out to the individual within 24 hours to provide that rapport and relationship. If the individual is experiencing homelessness upon release, we work closely with that individual to find temporary housing with the goal to find long-term sustainable housing. Some of the challenges that we've had, because our SMI program essentially onboarded during the height of the pandemic, and there was a mass exodus of individuals coming out of the county jail at the time. And because of the way in which they were being released, many of them did not have a discharge summary. They were not connected to any type of psychiatric treatment. Many of them had limited medication supply. And there was also some delay in getting them connected or linked to services because individuals, again, were getting released due to COVID. What we did to address those challenges was we linked clients to a program that provided a 14-day quarantine stay. So they were able to show that they were negative after that 14-day stay. That allowed us to connect those clients pretty quickly to needed services. In addition to that, we were able to order their meds through telehealth care. We ordered groceries online using various grocery stores in the area. And we had to kind of adjust our staffing scope of work to some degree because we were receiving these clients in such a long stream of people coming out so quickly. And so we just really had to be able to adjust in real time, be able to adapt and give the clients the support that they needed so they can, start off in that stabilization phase with some level of comfort. And so we are very diligent in how we approach doing this work. Many of our staff are also just as impacted with lived experience. We understand some of the social and psychological determinants that are the driver of the behavioral health and mental health. And so we provide both the behavioral health and reentry component, fusing those two situations together using the several modalities, which include cognitive behavioral intervention, motivational interviewing, and harm reduction. And so just proud of the work that we've done in the community and getting these individuals back on a successful trajectory. And with that, I'll mute. Thank you.
Thank you so much, Curtis. If we could please go to the next slide. I wanted to introduce our next speaker. So now we're going to hear from Indira Andrade, who is Program Director at Gandara Mental Health Center in Plymouth County, Massachusetts. Indira is a licensed mental health counselor who has been working in the mental health and substance use field for the past 13 years, serving your community and those who are in need. Indira, I'm going to let you take over and talk more about your program.
Thank you, Stephanie. It is a pleasure to be here to talk a little bit about our mission grant. My name is Indira, and I work at the Gandara Center. We are located in Massachusetts, and we were funded in 1977. The mission of Gandara Center is to promote the well-being of Hispanics, African American, and other culturally diverse population through innovative, culturally competent behavioral health, prevention, and educational services. The Mission Reentry program fits very well within our mission. And what is the Mission Reentry program? It is a reentry service that works with men who are incarcerated and being released within 3 months and returning to the Plymouth County in Massachusetts. The program serves men with substance use disorder or a co-occurring substance use disorder and mental health condition at 2 recovery centers that we have located in Brockton, Massachusetts and Plymouth, Massachusetts. Mission Reentry began in January 2019 in response to the high number of incarcerated individuals returning to Brockton and to Plymouth County upon release from their correctional settings. Since 2019, we have enrolled 282 participants, and that is the number that we've been that we serviced thus far. The process of the service, how we start is the case manager and a peer support specialist starts working with the men inside the jail by presenting the program. And if a participant is interested in the program, then they will approach our staff and talk to them about their interest in the program. We have staff that goes to the jail up to 4 times a week doing these presentations and also meeting in groups and individually with the participants that are interested. And we found that very quickly that had a great impact because the participants, while incarcerated, were building rapport with our staff. And that made it very easily, once they were released, to just continue working with them. So the participant discussed their needs with the staff while they're in jail, and also start looking at plans after their release on what they're going to work on. The day that the participant is being released, one of our staff goes to the jail and picks up the participants from the jail and brings them back to our recovery center. And at the recovery center, they are introduced to staff. They get a tour of the recovery center and all of the supports that they will be able to receive at the center, in addition to being a participant of the program. Once they are enrolled in the program, they work with a case manager and a peer support specialist. And there they discuss what the needs are. The case manager or the peer support specialist works with the participants in finding housing, employment, and also educational needs. They get connected to MAT services, make referrals to mental health and substance use services. We also make referrals to recovery coach services and all of the other needs that the participants may need at that time. Participants also are engaged in groups and individual sessions. And on top, they also attend social groups with other people that are in recovery. We found it very important to also expose them to a new environment. So taking them out to bowling, go out to the park, go out to the museums with other people that are also in recovery. Some of the challenges that we have experienced are helping participants to obtain housing and secure employment. The program supports participants up to 3 months of sober living. During this time, we encourage them and we teach them how to budget and how to save the money that they are making while working. So once these funds run out, they are able to provide for themselves and also to be able to pay their own rent. Housing is has been a very big obstacle for us. The price of rent in Massachusetts, and particularly in the city where we live, is very high. So finding affordable housing for our clients has been a very big challenge. And with that, also finding employment has been very difficult for some of our participants due to their criminal records. And in order to help and support them with that, the approaches that we've used to address these challenges are that the program staff will provide a character reference letter. They will go to the court and advocate for participants to help them overcome these obstacles of finding housing. And also we look a lot for quarry-friendly employment to help the clients get jobs. The key takeaways and lessons that we've learned is to always meet the participants where they're at. I know it might sound like a cliche, but not focusing only on the recovery, but also focusing on the root cause of the issues contributing to their substance use, and also to help with the needs that they are having at that moment. We found that just focusing on helping them on what the particular needs are that day, that time, has also been very helpful. Another big takeaway, we employ staffs with lived experience. Staff who are in recovery themselves can be supportive of the program participants. We also have staff that were incarcerated, so they were able to connect better with the participants because participants felt more comfortable with working with other people that has also gone through what they've gone through and has the same experience that they have. So we found that to be very powerful to have the lived experience. Other outcomes and benefits from enrolling in the program that we found after the 6 months follow-up is that 68% of the participants reported abstinence from drugs and alcohol at follow-up, compared with the 19% at baseline. The percentage of those reporting current employment or school attendance increased by 65% at follow-up, compared with 16% at baseline. And the percentage of those with permanent place to live in the community increased 25% at follow-up, compared with 1% at baseline. So at 6 months, we were really happy with the findings that we were finding that the participants had due to being enrolled in the program. We have built a great we've built a very good relationship with other entities in the community. We've been able to work with the Brockton Mayor's office. They help us to obtain identification, birth certificate faster than we would if we didn't have this connection. So we were able to help people get employed faster or get into housing faster due to these relationship. And also we were able to work with a lot of participants in helping them identify their line of work. So we had participants that, because they went through the program, then they found that they wanted to help other people that are also going into this, that has substance abuse or were incarcerated. So they would come and volunteer. And one of our success story, we were able to hire after 4 years, one of a participant that began in the program, and now he is able to work for this program and be able to help other people. So it has been very fulfilling to see a lot of our participants grow, and it's been very great being able to provide these services. Thank you.
Thank you so much, Indira. And I saw a lot of in the chat about the housing being an issue for other folks as well that are out there, so unemployment. So thank you for bringing that up. I would like to move on to our next speaker. And lastly, we'll hear from Sherry McKee. If we could please advance the slide. And so Dr. McKee will talk about the Living Free program in New Haven, Connecticut. The Living Free program is a partnership between the Yale School of Medicine, the Connecticut Department of Corrections, and the Connecticut Department of Mental Health and Addiction Services. Dr. McKee has been a professor of psychiatry at Yale School of Medicine for 25 years. So I'm going to let Dr. McKee talk about the program.
Okay, great. Thank you for that introduction, Stephanie, and hello, everybody. I'm also the clinical director of the Forensic Drug Diversion Clinic, or FORD, which is a clinic under the forensic branch of the state of Connecticut Department of Mental Health and Addiction Services. We provide outpatient addiction and mental health treatment to adults involved in the criminal justice system, with referrals coming from the courts and community supervisors. As we are a state facility, we are able to provide treatment to those without insurance. The Ford Clinic is located in New Haven, Connecticut, and despite Connecticut being one of the wealthiest states, we have very high rates of drug overdose deaths. We are currently ranked 10th in the US across the states, with New Haven County having the highest rate of drug overdose deaths in Connecticut. And prior to 2016, there were no services in the New Haven community that focused on substance use disorders for those returning from jails or prisons back to their communities. So at that time, we developed the Living Free program with funds from SAMHSA and have now enrolled over 750 clients in the past 8 years in partnership with the Connecticut Department of Correction. Living Free, our program, is based on a collaborative care model where we pair addiction and mental health care with primary care and peer mentorship. We start the process by identifying clients 4 months prior to release, and eligibility is primarily based on having a substance use disorder in need of treatment. Clinicians and peer mentors meet with clients at that time to recruit them into the program. 2 months prior to release, an addiction clinician and peer mentor meet again with clients to understand their treatment needs and to develop an individualized treatment plan. And then 1 month prior to release, clients go on an escorted visit to our clinic. The DOC has very generously transports clients down to our clinic for a half-day visit. They get to see the physical location of the client, get to meet with the treatment team, including an addiction psychiatrist. During this visit, we continue to build therapeutic relationships, continue to develop their individualized treatment plan, and identify which case management needs they need to have in place on the day of release. Our Department of Correction is able to start medications for opioid or alcohol use disorder in their facilities, and then we plan for the continuation of those medications. We also have a well-developed overdose opioid prevention plan and start with client education about overdose risk from the very first meeting. We also ensure that all clients have naloxone kits. Community treatment starts on the day of release. Addiction and mental health treatment is provided through weekly meetings with clinician. At Ford, our primary modality is individual treatments, and groups are adjunctive. Clinicians provide trauma-informed, evidence-based behavioral and pharmacological treatments. So in addition to medication-assisted treatment, we also provide medications to manage psychiatric symptoms when appropriate. We partner with a local methadone provider and also have a local primary care partner. We find that 35% of our clients have serious and chronic healthcare issues which need immediate medical care starting on the day of release. Peer mentors who have prior lived experience of substance use and incarceration are key members of our treatment team. Our peer mentors meet with clients frequently to provide ongoing support, which may continue daily through treatment. Peer mentors also facilitate weekly groups and provide case management services focused on housing, employment, and education. And we are also able to support brief stays in sober living situations for our clients. Treatment at Ford lasts for a minimum of 3 months, and we have no upper limit. A large proportion of our clients elect to continue in treatment long-term to receive ongoing recovery supports. We did continue to run this program during COVID-19 when staff were unable to go into prison facilities or see clients in person. At that time, we were able to transition our program to a telehealth format. And once we were able to see clients in person again, we maintained a hybrid format, allowing clients the flexibility of telehealth visits when needed. Our data shows that a large majority of clients, over 80%, are successfully supported in their recovery and in their communities. Our one-year recidivism outcomes are exceptionally low, 3 times lower than our state averages. I was also asked to address some lessons learned, so I'll wrap up with those. The first is to recognize that the first few weeks after release is an incredibly overwhelming time, and clients need much support during this transition. And the second is that the treatment team must be committed and provide a welcoming environment. And I absolutely credit the success of our program to our staff and the environment that they create. Thank you.
Thank you so much, Sherry. And thank you to all of our case study presenters. These 4 case studies provide an excellent snapshot, I think, of the specific instances of implementation. And I encourage folks, if you have additional questions, to contact the presenters directly if you have any questions. So in the interest of time, I'm going to go a little bit quickly through the next few slides. Chapter 3 includes sections that cover implementation considerations and strategies for organizations, coalitions, and clinicians and other staff members, and implementation resources for each of the 3 interventions described earlier, as well as other resources. Next slide, please. Thank you. And then I wanted to briefly mention the last chapter, which is chapter 5, on resources for evaluation. So program evaluation can occur at varying levels of depth and rigor through multiple approaches and for different purposes. So evaluation can answer important questions, for example, about which aspects of the program are working and those that might require modifications. Evaluation can also help identify whether programs are being implemented as intended and also show how individuals are impacted by the intervention. This chapter also provides an overview of continuous quality improvement, which is a process of assessing program implementation and short-term outcomes. So a lot of good resources in that chapter as well. So I want to give us enough time to wrap this up. So I'm going to introduce very quickly Barry Zach. He is our subject matter expert, and he's a principal consultant at the Bridging Group. He's also a national expert and international consultant in the field of correctional and community health, including prison, jail, and other detention settings and subsequent community reentry. So I will hand it over to Barry to wrap us up.
Thank you, thank you, thank you. And thank you. It's so important to hear these field reports, the reality of our reentry efforts. I know that when I was a SAMHSA grantee some 20 plus years ago, this guidance would have been incredibly useful. I know it was just mentioned, but I do want to acknowledge how COVID changed everything in reentry. It made it so much more challenging than it already was. And then when we were able, we became creative, dynamic, and developed new ways to do our reentry work. I'd like to highlight some key takeaways as a call to action. The guidance in each of the case studies show how critical it is to take the big picture of research-based evidence and make it your own. Make it work for you, the population you work with, the jail or prison setting you work in, your community, available resources, wherever you are. They are not the same. We know when you know one jail in one community, you know that one jail in that one community. And it's challenging because there's so much to do. Some unique approaches I heard, we just heard about in New Haven, truly amazing. After 40 years of doing reentry work, I have heard and seen some creative, effective strategies, but yet to hear about this, this relationship between the clinic program and the DOC and these pre-release visits to the clinic. Also mentioned was in the guidance is about addressing secondary trauma with staff. This is a huge unknown, how the work we do triggers trauma in the staff, addressing all the participants with trauma, and there's so much trauma. We expect so much from staff that's working with a challenging population. We really need to understand this dynamic better and provide more support to frontline staff. The data are also overwhelming about the risk and chaos of the first hours and days after release from custody. We need to improve immediate release planning to support treatment engagement. And as was just mentioned in the chat, and housing and shelter upon release across the board is the most challenging issue that people face upon release from custody. It's becoming more challenging as housing costs increase and beds are more limited. and we really need to support our clients. Do you ask, where are you spending your first night out, and work to support those housing, post-release housing? To close with, peers have tremendous pro-social influence and are great mentors and models of success. Having staff with lived experience can be challenging regarding security clearance and access to the facility, but regardless, there are roles for peers, and the data, the science shows this improves linkage to care. So what we're hearing, participant-centered, harm reduction, MOUD, peers, navigation, case management, and working with people pre-release, at release, post-release. We also know that our clients have comorbidities, not just substance use and mental health disorders. An example is in a recent systematic review on HIV clinic attendance post-release. I quote, interventions that demonstrate post-release improvements in clinic attendance and viral suppression include patient navigation, including peer support, and substance use treatment strategies. Improved that linkage. So the big takeaway is relationships. One doesn't just break into prison. You know, it takes time to develop the respect and trust of those people that are incarcerated, as well as medical and custody staff to do this important work. And I just want to mention one topic in our efforts, and that's the prevention of reincarceration. There's a whole science on that topic, and we really need to integrate this into our programs. So I thank you. I know you all have very full plates with many side dishes. You're busy, so I thank you for taking the time today to learn about this resource, and thank you for all the important and challenging work that you do. To learn more about the policies discussed in the guide, you can download it on the PowerPoint right now from the SAMHSA store, or from email SAMHSA's EBRC team at the address provided. We'll be happy to answer your questions or connect you to the presenters if you have a specific question. I'll now turn it back to Felicia, who'll tell you how you can get access your certificate of completion for attending today's call. Thank you very much.
Thank you, Barry, so very much. And thank you to all of our amazing speakers today, to SAMHSA, to Abt Associates, and to everyone who has contributed to the development of this guide. For very quick next steps, we have a brief survey that if you are able to take, it helps inform our practice in the future, and we would appreciate all of your opinions. This will also be sent out in a follow-up email with the recording, the slides. Many of you asked for the transcripts. All of the material that we're able to share, we will share. You will receive that within a couple of days. Otherwise, please take our survey if you're able. And it was really special to be able to share this hour with you all. Thank you for those who hung on just a little bit as we went a tiny bit over time. Really appreciate all of you. And thank you again to all of our speakers and everybody who made this event possible. Thank you all. You will receive your follow-up email.